Olá a todos, eu sou Luiz Otavio Caboclo do Hospital Albert Einstein, São Paulo e da Faculdade de Medicina do Hospital Albert Einstein. Bem-vindas e bem-vindos ao novo podcast da Liga Brasileira de Epilepsia, uma iniciativa da LBE para divulgar aspectos científicos relacionados à epilepsia. E hoje no nosso novo podcast nós temos o nosso primeiro convidado internacional e ninguém melhor para abrir essa série internacional do nosso podcast do que o Dr. Nickolas Abend. Dr. Abend, ele é neurologista infantil, ele é médico no Hospital Infantil da Filadélfia, o CHOP, onde ele coordena o serviço de epilepsia, ele é professor de neurologia e é diretor da Divisão de Neurociência. A gente vai falar bastante sobre crises epiléticas, epilepsia no ambiente de UTI, principalmente UTI pediátrica, eletroencefalograma e as visões do Dr. Nickolas Abend sobre o futuro dessa área. Well, welcome, Dr. Nickolas Abend. It's a pleasure to have you once again in Brazil, and it's a pleasure to have you as our first international guest for the podcast of the Brazilian League of Epilepsy. Welcome.
Thank you. It is great to be back in Brazil, seeing so many friends, and it's an honor to participate in this podcast.
Great. Just to start, I'd like to hear from you. What's your background? How did you get to pediatric neurology and pediatric epilepsy and ICU, EEG, and seizures in the ICU?
As I was training, I was really always interested in the brain and sort of neuroscience. And then I loved my pediatric rotation, which led to pediatric neurology as a decision. And then when I was training in pediatric neurology, I actually initially didn't think I would do EEG. I thought I wanted to interact with patients more, and I really loved my neurocritical care consultation time. But I realized a tool that I could bring into the ICU as a neurologist that really could help the intensivists and help patients was EEG and neuromonitoring approaches. And so that led me to train in EEG and really develop, hopefully, techniques that could benefit care in the intensive care unit. And it's worked out well. I've had great colleagues around the world in neurology and critical care medicine and neonatology to collaborate with both for research and clinical practice. And it's worked out well so far.
Yeah. We know EEG is probably the most powerful tool for detecting seizures in the ICU, both in the ICU and outside the ICU. But what is the importance of detecting seizures? How common, how frequent are seizures in the ICU and specifically in the pediatric ICU?
So we've really, I think, begun to answer that question in the last 10 or so years. And what's been surprising is that a large number of patients are seizing in the pediatric and neonatal intensive care units, I think similar to adult critical care. And it depends a little bit what indication you're using EEG for and what patient cohort. But for most of the groups that we think about it, about 20 to 30% of critically ill patients with different types of neurologic injury are experiencing electrographic seizures. And that crosses babies with hypoxic ischemic brain injury, stroke, traumatic brain injury, patients after cardiac arrest, brain infections. All of those conditions are around 20 to 30%. And the majority of those seizures we wouldn't see just watching the patient. There isn't a clinical convulsion or typical seizure. It's that they are looking encephalopathic with altered mental status, and the only way we know they're seizing is through EEG monitoring.
Yeah, this is a very important point, as many seizures would go unnoticed without EEG. In many places in the world, and this is like we have in Brazil, we have some difficulties in assessing EEG and specifically continuous EEG monitoring. So among all these patients you referred to, what are the group of patients of which you should be especially aware of the possibility of them having seizures, the patients who would really have to get some kind of EEG? What tips can you give us in order for us to detect those patients who are at higher risk of having seizures?
Yeah, so we've done a lot of work in this, and other people have too, trying to figure out the risk factors for subclinical seizures. How can we target EEG since it is so resource intense to the patients most likely to benefit? And I think the themes that come out are patients who are encephalopathic or comatose with an acute neurologic problem are the ones who are the most at risk. So patients who are just sedated but no specific neurologic problem, or patients who are more awake but in the ICU for various reasons tend to have a much lower risk. But about 20 to 30% of encephalopathic, doesn't have to be comatose, just encephalopathic patients with an acute neurologic problem. And then I think the other finding is abnormal events. And those are tricky because often we find that abnormal events are not actually seizures, vital sign changes, little twitches and things like that.
Which are very common in the ICU.
Yeah, they're incredibly common. And so figuring out they're not seizures can be helpful so that we're not escalating treatment, chasing things that are not seizures with more and more drugs. But also I think they're sort of useful identifying factors that make people think this patient is at risk for seizures. And even though the little twitches or vital sign changes may not be seizures, often those are patients that now people are thinking they do have an acute neurologic problem, they're encephalopathic, and we'll find subclinical seizures in them.
Great. So it's important to highlight that EEG is important both for detecting seizures that would go unnoticed and to detect other movements which are not seizures and should be not treated as seizures, because these would be iatrogenic, of course. Your group, among others, have established this number, which is very impressive. Approximately 30% of patients have seizures, approximately 15% have status epilepticus. But then many of these patients, many of these seizures are only detected with EEG. How do you compare the routine EEG in the ICU with the continuous EEG monitoring? Keeping in mind that in most places we don't have continuous EEG monitoring. How good is the routine EEG to detect seizures and other events in the ICU?
Yeah, so, well, the first thing I'd say is, for your point about 15% who have status, I just emphasize that is with us attempting to treat patients who have electrographic seizures, and therefore they may not go on to status. If we were not identifying the seizures and not treating them or not treating them till later, we might find a larger percentage had status epilepticus. So in a way, that's kind of the tip of the iceberg in terms of the incidence of status epilepticus. So we've looked at the timing of seizures, and I think across different cohorts and age groups, the first hour or two are definitely the highest risk period. About half of patients who are going to have seizures do so within the first 30 to 60 to 90 minutes. So I think the first lesson we've taken is even if you can't do very extended monitoring in everyone, there's a good yield to doing a briefer study, 30, 60, 90, at least a couple hours in a lot of patients, because you're going to have a decent yield in that. And also that it's important not just to hook up the EEG and walk away, but really looking at it in the initial couple hours to see if they're seizing to act on it is really important, because that's such a high yield period. But beyond that, another half of patients we don't pick up unless we do longer monitoring. And that tends to be about 1 to 2 days in most patient groups to get about 90 to 95% of patients. And then there's a small percentage that we'll seize later. These aren't stable patients. Their neurologic problems are fluctuating, the drugs they're on are fluctuating. So exactly when the time starts gets a little tricky. Is it when they get admitted, when things get worse or change substantially? Does that start another period of high risk that they should stay on monitoring longer? But I would say for the majority of patients, we aim for about 1 to 2 days.
1 to 2 days. Anyway, I think the important message is first, some EEG is better than no EEG at all.
Absolutely.
Absolutely, of course. If we have a 2-hour EEG, this is great. This will help in many patients. And of course, when available, the continuous EEG monitoring is superior to EEG. But then, okay, you detect the seizures, but what is the impact of these seizures, specifically when we talk about children? What is the impact of seizures and status epilepticus in these children who are admitted to the ICU?
Yeah, so we think there were a number of studies that showed that seizures were associated with worse outcome. Especially high seizure burden or status epilepticus. And one of the questions that persisted for a while was, are the seizures actually causing the worst outcome or contributing to it? Or are they just biomarkers that the patient has worse brain injury, and so they seize and they have a worse outcome? Over recent years, there have been a number of studies that have tried to address that by doing multivariable analyses that address how bad is the brain injury, what does the background EEG look like, what is their coma score, various clinical variables like that. And even in those adjusted analyses, we find that higher seizure burden is associated with worse outcome. And we've looked at that with short-term outcomes like mortality and various outcome scores in pediatrics that are used, as well as some longer-term outcomes. And a number of different investigators have done this type of analysis in slightly different ways. But the key theme seems to be very brief seizures don't affect outcome, but in a dose-dependent way, high seizure burden is associated with worse outcome, even after those adjustments.
Yeah, because I mean, for ethical reasons, of course, we will never be able to perform a study where we treat some of the kids and do not treat the other kids in a blind way. All the children who have seizures detected in the EEG will be treated. But sometimes we have some doubts. How aggressive should be the treatment? Going a little bit deeper in the EEG. Of course, if you have status epilepticus, you're going to treat. If you have isolated seizures, should you escalate on treatment? And if you have some patterns in the EEG, specifically a rhythm, periodic patterns, should you treat them all? What is the objective of the treatment? How aggressive should you treat these children?
Yeah, so I think that is really where the field has gone over the last couple years, and I think where it needs to go in the future. We've worked out a lot of the epidemiology. These seizures are common. Now it's about what we do about them. And I guess I have two main thoughts about how aggressively to treat. The first that I think maybe is less considered is that one form of aggressive treatment is identifying the seizures quickly and acting quickly. And there's some data that no matter what drug you use, if you give it sooner, it will be more effective than if you give it later. So potentially by checking the EEG more often, over time, I think implementing new quantitative and AI strategies to detect seizures quicker and intervening quicker, we may have better effectiveness, need fewer meds, have fewer side effects, stuff like that. And so I think that sort of rapid intervention is part of the aggressiveness.
Yeah, it's very interesting. You have published in the past a paper showing that there is a significant delay in treatment, both adults and children with seizures, even when they are inside the hospital. The seizures take long to be detected, and even worse, they take long to be treated for the first time. So how can we improve these treatment strategies in adults and children?
Yeah, we have shown that it takes sometimes a couple hours, despite our best efforts. We have to look at the EEG, which we don't do continuously, but we do every 30 or 60 or so minutes. Then the EEG reader would call the neurology doctor, who would call the intensivist, who would be finishing important work, resuscitating someone, and eventually order a seizure drug, which would eventually come from pharmacy, and the nurse would administer it, and time would have passed. So I think, and people have shown that in neonatal intensive care units and a variety of settings. And I think that a key approach has been to think about the pathway in advance. If we saw seizures, what would we do to treat? What drug would we use? Do we have the most common drugs available in the intensive care unit or more rapidly available? Can we eliminate some people from the phone chain that we have? And sort of treat much more quickly in that way. And I think the future will also hold seizure detectors, quantitative EEG approaches at bedside. All of that is sort of coming into practice now. But even to date, there are a number of studies that have shown just thinking about the pathway in advance, what's the clinical management we're going to do, can really speed things up and make the initial drugs more effective.
Of course, because it's important to remember that we should have a pathway. Every hospital should have a protocol for treating seizures and status epilepticus, both in the emergency unit and the ICU. It's important to treat fast. More and more, we use an aphorism from the stroke neurologist, which is time is rain. And I think we are comfortable to say that time is rain when it comes to seizures and status epilepticus. We have to act quickly, but of course we have to detect quickly. Changing gears a little bit, what about neonatal seizures? In which way neonatal seizures differ from children and adult seizures in the ICU?
So in many ways they're similar, maybe most ways. They are often acute symptomatic, caused by some problem going on in the brain right then, as opposed to epilepsy. In babies, it's most often hypoxic ischemic brain injury, but they also have stroke and infection and various other problems. They tend to have a very high seizure burden early, and then the seizures tend to fade out over days to a week or so, even if you don't do anything. And so one of the important features of that is if we're going to lower the seizure burden, it's going to be high at the beginning, and we got to act quickly and sort of aggressively at the beginning. And that's really important in that population. I think the other finding we've had a lot in babies recently is that if we're escalating treatment quickly to block the seizures at the beginning, most of them don't need long-term treatment. It's actually a very small percentage that will go on to develop epilepsy later. And so we want to watch them carefully and give the parents education about what to watch for. But the majority of babies will now withdraw the seizure meds relatively quickly, and then see what happens, knowing only a very small percentage will go on to develop recurrent seizures. And I think that even emphasizes more the importance of sort of a rapid burst of therapy, detection with good EEG monitoring, using seizure meds, ramping up when needed, but then also as soon as the seizures stop, knowing that we can pull back and not expose them to these seizure meds for long term that they may not need.
Yeah, and we should remember that maybe in the neonatal ICU, it's even harder to detect seizures because many of the seizures are purely EEG seizures. And on the other hand, these babies, they make lots of movements which are very strange, with maybe look like seizures and many times are not seizures. So the video EEG monitoring, I think it's fundamental for this in this setting, isn't it?
Yeah, I think all of the things that we talked about in pediatric and adult are really emphasized even more in neonates, that they have a high seizure incidence, especially with hypoxic ischemic brain injury, where maybe about 30 to 40% have seizures. The seizures are predominantly subclinical, non-convulsive, EEG-only seizures that we wouldn't know about without EEG. They often have a high seizure burden over a relatively short period of time. And when we treat with some of the initial meds like phenobarbital, we know that we can block the clinical convulsions if they were there, but subclinical seizures persist. So for all of those reasons, I think we're using EEG a lot. And then, like you brought up, they have a lot of abnormal movements that are hard to distinguish, especially in a baby with brain injury. Jitteriness and increased reflexes versus seizures can be very difficult. Even to skilled observers, they're often inaccurate and often don't agree with each other about what a seizure is. So EEG really can provide the answer. And an interesting finding of some of the neonatal papers has been that when intensive care units implement EEG in this way, overall phenobarb use actually tends to decrease a little bit. And they're finding more patients and more seizures to treat, but also some of the unnecessary use is not happening, where they're going to higher and higher doses for things that were not seizures to start with.
Clearly, they are treating better the patients, the ones that have to be treated.
Accurate.
Amplitude integrated EEG, or AEEG, is becoming more and more popular, especially in neonatal ICUs. What do you think about AEEG? How does it compare to the normal, the routine EEG?
So AEG is one of several quantitative EEG techniques, but definitely the most talked about in neonatal intensive care units, where a smaller number of electrodes can be applied to the head, usually 2 or 4 instead of a full array of electrodes. And the machine is able to process the data to look for changes in amplitude and squeeze time together so that instead of seeing, say, 10 seconds on a page of EEG, you may see several hours on a screen of amplitude EEG. And so it can be sort of more easily applied, and bedside clinicians can learn how to interpret it. And it's been around for a while. There are a lot of studies that have looked at how well it works. And I think the answer is that it's imperfect, that it does detect some patients with some seizures. It tends to be the seizures that are longer, so they last long enough to be detected with this technique that's squeezing together time, and seizures that have a big change in amplitude, because that's all it's looking for. And so it will detect maybe about half of patients with seizures, less than half of actual seizures.
It's not that good. Half of patients doesn't look very good.
It depends if you're comparing to clinical observation alone. It may be better than that as an added tool to bring. But compared to conventional EEG, it is inaccurate. And clinicians can get better at using it. Experience matters. You can get more trained and things like that. But there are also just limits to the technique. If the seizure doesn't happen in a part of the brain being recorded with your limited electrodes, you won't see it. If the seizure doesn't change in amplitude, it's not going to pick it up. Or if it's brief, like most baby seizures are, it may not last long enough to generate one of the nice arches that people look for on amplitude integrated EEG. So I think the future is probably, I hope, a little less, is it good or bad, and one over the other. I think the future likely holds some hybrid strategy where we may have something at bedside that we're using. It may be amplitude EEG or something fancier, other quantitative EEG trends and panels. And then neurophysiologists, electroencephalographers, are also using conventional EEG for high-risk babies, for the right time periods that are highest risk, or to confirm findings on amplitude integrated EEG. And
probably in a more cost-effective way, because since it's not available everywhere, we have to choose very well the patients who will mostly benefit from conventional EEG and continuous EEG monitoring. In your opinion, maybe EEG at this point would be some kind of screening tool for indicating conventional EEG?
Yeah, either a screening tool or for use for longer in patients who we think are at low risk for seizures. And there may be groups where we're okay with missing some brief seizures. It is a dose-dependent system, and missing a single 30-second seizure may not be a failure.
Yeah.
But there may be groups that we figure out we just want to make sure they're not in status. And so I think the future probably will use AEG or other related techniques as sort of a screening approach with conventional EEG interpretation. So that sort of make use of someone at the bedside, but also neurophysiologists who can have higher accuracy. And there's some data that works in places that have tried it. You can reduce, for example, the false positives. Do you see something on amplitude EEG that wasn't actually a seizure, and you escalate treatment? Well, a neurophysiologist looking at conventional EEG for just 10 minutes around that event could tell you, was it a seizure or was it a false positive? And therefore, with a relatively small amount of conventional EEG reading, you could potentially decrease the false positives.
Right. With respect to treatment of neonatal seizures, I understand we have much more restricted resources to treat seizures in the neonatal ICU. We have fewer drugs that can be used and that have been studied. Why is it so? How do you view this limited availability of pharmacotherapy for neonatal seizures? And how can we get better?
Yeah, I think that's it's a big question. I mean, I would say it isn't only neonates. It's acute symptomatic seizures and status epilepticus in all ages that we need to keep working on therapies for. Some of the initial, a large proportion of patients don't respond to initial therapy and need escalating therapies and additional drugs. But neonates have had a unique challenge that it is hard to study drugs in them. People tend to be nervous until there's data in adults and other groups that the drugs are safe. There are fewer neonates that have seizures. It's a little tricky to enroll in studies compared to older populations or outpatient epilepsy, since you have to catch them while they are sick and in the intensive care unit while you're trying to treat quickly. But despite that, there have been some studies, and we do have some approaches that work for the majority of patients, with phenobarbital, phenytoin, levetiracetam sort of being the big three drugs often used in that order.
Okay, moving on to more severe cases. In children, adults, status epilepticus. We have good evidence for first-line treatment of status epilepticus with benzodiazepines, for second-line treatments with IV and anti-seizure medications. But when it comes to refractory and super refractory status epilepticus, we do not have good evidence up to today. How do you view this issue? What are your thoughts on this? How can we improve treatment of refractory and super refractory cases of status epilepticus?
Yeah, probably about a third of patients will keep seizing despite some of those initial drugs, benzos and one or two seizure drugs. So it's not an uncommon thing for us to see refractory status and super refractory. We're in the ICU for days, weeks with high-level therapies. We tend to, and I think you're right, there's much less data available for comparing drugs in that setting. The couple themes that we try to follow are first, again, the importance of early treatment. Give drugs quickly. If they don't work, escalate. Quickly. And then we'll generally go to midazolam drip as our first approach. And with midazolam, I think some of the key themes that we've found, we'll often give boluses relatively frequently. If they're still seizing, about every 15 to 30 minutes, we'll give another bolus of midazolam. And then we're increasing the infusion as well. But it's really the boluses that we're looking at to stop the seizures. The infusions are hopefully just maintaining the level for longer. And sometimes I know at night there can be a tendency to just tweak up the infusion a little bit, but it's really the boluses that are giving you a higher drug level quickly and hopefully stopping the seizures. We aim for seizure suppression. We generally will get burst suppression at the same time, but we're aiming to stop the seizures based on conventional continuous EEG monitoring interpretation. And then and that works for a lot of patients. The third theme I think we try to emphasize is that in alone by itself isn't definitive therapy. We're really buying ourselves a window with something like a midazolam drip to think about what's the etiology, what specific therapy we need, how do we add on other seizure meds so we can wean off the midazolam. If we think we're going down the FIRES or sort of immune approach, how do we think about initiating immunomodulatory therapies or the ketogenic diet? In new patients, is there any chance this could be a surgical epilepsy, that it's caused by a lesion? And if we act quickly with sort of the usual refractory epilepsy surgical approaches, we might be able to intervene. So we're trying to think a lot in that window about what's the definitive etiology, what specific therapy we can give.
Yeah, because usually we know the treatment for refractory status epilepticus is based on the use of continuous anesthetic drugs, midazolam, propofol, pentobarbital, thiopental, and more recently ketamine too. What's your experience with ketamine for treatment of refractory status epilepticus?
So we have used ketamine a lot because many of the patients that we're taking care of are critically ill beyond just their status epilepticus, and people are often worried about some of the hemodynamic effects of midazolam and especially pentobarbital, where ketamine doesn't seem to have those things. Mechanistically, it's also interesting that a lot of the other drugs we've often used before we get to ketamine work on GABA receptor type mechanisms, and ketamine is different, NMDA. So in terms of thinking about alternate mechanisms, it sort of makes sense. And we've had, and some of the data we and other people have published show that it seems to work as well as some of the other conventional anesthetics like midazolam and pentobarb, maybe with fewer of those hemodynamic side effects.
Do you use it with midazolam, ketamine?
So we are sometimes now using it even before midazolam, figuring it's worth a try. And if it doesn't work, then we go on to midazolam. We're very often using it before pentobarb. If midazolam doesn't work, we'll try ketamine before going to pentobarb, which in kids seems to have more hemodynamic and adverse effects potential.
Yeah. Well, and probably the most frightening picture we can see, super refractory status epilepticus. You touched on the importance of finding the etiology. If we not find the etiology, it's very hard to have a good result. And many times when facing patients with super refractory status epilepticus, we have this clinical picture of new onset refractory status epilepticus, or NORSE, patients with no previous history of epilepsy, and a very severe presentation of status epilepticus, refractory or more often super refractory. There are very limited data on the treatment, on the management of these patients. A recent consensus suggested some points of investigating and treating these patients. What are your views on this, on treatment of NORSE and FIRES? Tell us something about, first of all, the difference between NORSE and FIRES, and how would you manage these patients?
Yeah, so I think that there's been a lot of overlapping terminology in the literature that some of the recent consensus statements have tried to narrow a little bit. So the idea now is that NORSE, new onset refractory status epilepticus, is the overarching subtype of continuing status despite several medications. And then FIRES is a subtype where you've had recent febrile infections and you don't find another etiology, and you think it may be related to immune mechanisms underlying. And then there are other descriptive terms we can apply, like super refractory and prolonged and things like that, for status that goes on days or weeks with different levels of anesthetic use. But the idea is that FIRES is a subtype of NORSE. And a key theme, I think, for why people have tried to redefine these terms is that they shouldn't be exclusively retrospective diagnoses that we make weeks later after all of the testing we could possibly do is back. They should be early diagnoses because that will let us think about pathways, even as some testing is still returning, for how we treat more aggressively early in the course. And like you said, these consensus statements, I think, provide a nice pathway for things that we should think about early, like immune therapies, the keto diet. If we're going to do those things, they will probably be more effective if we implement them over days to a week than after the patient has been in super refractory status for weeks or months.
When the chance of having a good result would be much lower, of course. In NORSE patients, how early would you consider immunotherapy for adults and children?
Within the first several days, for sure. It often takes about a day or two to sort of stabilize the patient, do the initial diagnostic testing, neuroimaging, CSF analysis, things like that.
And exclude some treatable causes, such as infection, for instance.
Yeah. And that can take about a day, maybe 2 days. But we don't wait for every lab test to come back. And
especially the antibodies for autoimmune encephalitis, which take many weeks usually to come back from the lab, so we cannot wait for the results to start immunotherapy, right?
Yeah, exactly. So within about a day or two, if we think we're going down that path, we're starting immunotherapy. Generally, as we're starting immunotherapy, we'll start thinking about sending labs for ketogenic diet, some of the pre-diet labs we would want for safety, figuring that we may be going to that over the next couple week or so. And we want to get the pre-work done. So we're trying to really move everything up from being, trying 3 or 5 or 8 typical seizure drugs, first before getting to immune therapy or the keto diet, to trying some of those things at the same time, but also using immune modulatory therapies and keto diet earlier.
Yeah, I believe in most places the threshold for initiating immunotherapy is getting lower. If you don't have an identified cause in the first days, and immune etiology is a possibility, maybe we should go faster than slower to immunotherapy.
Yeah, I agree with that, and that seems to be the trend that people are reporting, and that many of these pathways are suggesting is move to those things earlier where they're more likely to benefit.
Right. And what's your experience with ketogenic diets in the setting of super refractory status epilepticus?
That it can work well. That for some of these patients, we're now using it at about 1 to 2 to 3 weeks if the immune modulatory therapies haven't worked. So we're using it much earlier. That it is effective in a large proportion of patients, but also that it's tricky. It requires a team.
What are the tips you could give us in managing a kid with ketogenic diets? What are what should you take care with?
I'd say if I had one tip, it might be involve a pharmacist.
Great, yeah.
Because getting rid of some of the glucose and adjusting some of the other infusions and meds can be really effective and necessary to induce the ketogenic diet. And then having, where I work, a mostly outpatient ketogenic diet team has, over the last several years, really transitioned to pretty frequently being involved with 1 or 2 inpatients that they're helping to initiate the diet quickly and help with all of the tips and tricks for making sure that the other meds and fluids are appropriate with the diet.
So that it can work, of course.
Yeah.
Great. Well, this is a long discussion. We could go on forever here, but we have a limitation of time. So just to finalize, Nick, I'd like to hear from you. What do you think is the future of treating seizures in the ICU, specifically in children? This is your main activity. How can we improve in the future the detection and managing of these children with seizures in the ICU?
Yeah, so I think that's the big question that I think so many of us are thinking about. I think that we've really figured out a lot of the basics about seizure epidemiology and EEG, the importance of EEG monitoring. And while we have limited drugs, we do have therapeutic options that are available and effective and safe for many patients. I think that maybe the near future is going to be about pulling all of this together into efficient, sustainable, quick strategies. For this to be neuroprotective, it can't only be feasible at a small number of institutions, but we need to find ways to make it broadly available. So I think it will be building on sort of the foundation that we have now, conventional EEG with EEG techs and neurophysiologists and sort of the typical treatment strategies to make it all more sustainable. And I think that will be combinations probably of quantitative EEG trends that neurophysiologists are using and that are displayed at bedside, seizure detectors, and quicker strategies for implementing therapy when we find seizures.
And hopefully getting access to more children, more pediatric ICUs to have these kind of resources so that we can benefit more children with the so severe cases.
Yeah, I think clearly more access, like you said, is important for clinical management. If we want this to benefit kids, we have to have it something that we can make available to more kids. I think also some of the standardization that's happened to date and implementation in more places may help us develop the best solutions. So like you said, I don't know that we're ever going to have a randomized trial where we don't treat seizures. But different centers and countries may intervene in slightly different ways. And if we have some degree of standardization and networks that can study this, then we can do comparative effectiveness research and sort of become a learning health system or learning health network of neurologists and intensivists and neonatologists who can make use of some of the differences to actually compare different strategies.
Great, and maybe this is a very good opportunity for collaboration between Philadelphia and São Paulo, between United States and Brazil. Hopefully in the future we can do this together and find better ways of treating these children.
Exactly. I would love that.
Great. We too. So Nick, thank you very much once again for your kindness of being here with us. It was very special to have you here as our first international guests in our podcast of the Brazilian League of Epilepsy. And I hope you have very good days in Brazil.
Thank you. I am honored to be here, and it's great to see you and so many friends.
Thank you. Muito obrigado a todos. Esse foi o podcast da Liga Brasileira de Epilepsia. Siga a Liga Brasileira de Epilepsia nas redes sociais. E nós esperamos sugestões de novos temas para os nossos podcasts. Esperamos ver todos nos nossos próximos episódios. Muito obrigado a todos.